In a world of healthcare, where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening, colleagues. We are back, and it's exciting times once more as we continue with our clinics health group webinars. And we missed you for the last few weeks, and we trust that you had a good festive season and you are well on your way in establishing your routine and with new ideas and new thoughts for this new year, 2024, January 2024 tonight. On this 25th day of January, we just want to welcome all of you from various parts of the country. I see some people are logging in from George. It's good to see you also, colleagues from George, and those in Johannesburg and outside of Johannesburg, other provinces and Northwest, wherever you're looking, and colleagues also from the public and the private sectors and different disciplines, specialists, medical officers, colleagues from the allied health professions. We just want to welcome you, and we trust that we shall have a good year as we continue with our webinars. And we starting on a good note, starting with a topic on ethics. And so please also note that as usual, these webinars are CPD accredited, and we streamed live on YouTube also, so you'll be able to access this year's presentations, even the past presentations on YouTube. But we request that as you log in, you just mute yourselves and also switch off your videos. And so it's exciting, as I indicated, that we have one of our own in clinics and also in various sectors in the private sector where she is working, and also has quite an experience in the public sector and academia. So we have Professor Chris Lundgren who will be talking to us on professional and ethical behavior in theatre. And as you shall have noted in our invitations that we sent you, she's quite an accomplished professional who's currently based at the Wits Donald Gordon Medical Center as the clinical head of governance and other associated committees on a part-time basis. She's also the chair of the ethics committee at DGMC since April 2020, and also a member of the risk committee, Clinics Health Group. She's also a part-time member of the Steve Biko Bioethics Center at Wits. Professor Lundgren is an anesthesiologist by training with special interest in cardiothoracic, liver and vascular anesthesia, neuroanesthesia, ethics in anesthesia, particularly informed consent, as well as health law in South Africa. We hope that later in the year, we'll be talking more about informed consent, which is one of her passions also. She has also supervised numerous Meds to completion, as well as one PhD, and her PhD thesis looked at procedure-related deaths, importantly those due to anesthesia, at two universities, teaching hospitals in South Africa, over a 5-year period. And the MSc this investigated the quality and type of informed consent given by research subjects in major university research units. And the degree was awarded with distinction. She's got several memberships in anesthesia, where and also is a member of the Society of Anesthesiologists, also national president from March 2004 to 2006. And she has also served at an international level in various capacities as a member, an accomplished anesthetist. And so we just want to welcome you, Prof. Lundgren, this evening as we kick off our first webinar for the year. And it's such a pleasure to welcome you, someone that I've worked with for several years at Chris Hani Baragwanath Hospital. Now we are working together at Clinics Health Group. Thank you and welcome.
Thank you very much, Dr. Bila. And good evening, colleagues, and thank you so much for attending. I'm passionate about ethics and patient safety in theatre. And I've been in anesthesia. I was in anesthesia for 39 years until I was forced to retire from the province. And I've been at the Donald Gordon. This is now coming up to my 6th year. And trying my best to give back to the profession and make our patients' safety through theatre, their journey safer through theatre. So there's an awful lot being written about professional and ethical behaviour in theatre currently. The literature is just overwhelming in comparison with even sort of 2 years ago. But my slides won't advance. I don't know why.
Prof, if you can click anywhere on the slide and then move down.
Oh, there we are. Sorry. Okay.
You.
Oh, no, I'm going the wrong way. Woo! Help me. I'm going to stop sharing and start sharing. Sorry. Okay. No, it's halfway through.
And maybe just click on the laptop. Don't use the mouse. Just click on the arrows to go backwards.
Yeah, I'm going to. I just want to get it on the first slide. Right. No, it's still not. Okay. I must go back.
Yeah, just go back, yeah. Sure.
It's not working.
Just click on the...
Prof, may I suggest that you close your presentation and reopen it again from scratch?
Okay, I will. Sorry. Oh, that's what's happened. I've got two versions of it. Okay. Apologies. Share screen. Okay. Sorry about that.
Thank you, Prof.
Okay, so if you read the literature, and I think we all know for ourselves that patients are more likely to experience preventable harm during perioperative care than any other type of healthcare encounter. And that's quite a daunting statement for those of us who work in the perioperative space. And if you look at the general contributing causes, the literature lists 4: communication breakdowns, diagnostic errors, poor judgment, and inadequate skill, bearing in mind that this is the entire perioperative journey that our patients are involved in. And I've highlighted communication breakdowns and poor judgment because those are the areas which I'll be focusing on. And in our operating theatres, never events constitute a significant component of preventable harm. And never events are those which are really serious events, such as wrong patient, wrong surgery, wrong side or site, wrong device or wrong implant, or heaven forbid, leaving swabs and instruments behind. So those are generally classified as never events. And I will deal with those in a minute. So if we look at our professional and ethical behavior, what do we mean? I will highlight what I think we mean and also how we tackle this. Why is a no-brainer? It's to improve patient safety. And that is, I think, what we all need to strive for, is to improve our patient safety. And who should be involved? And it involves nursing staff, all the doctors, allied, cleaning staff, the entire theatre team. I've listed at the bottom 3 of the numerous articles that I read, which I find very useful. And my slide presentation will be available. And if anybody wants additional articles, I'm very happy to share. So what do we mean? We mean that we all work in theatre under the foundational basic ethical principle of primum non nocere, which is first do no harm. And every single member of our operating theatre team should have one thing in mind, and that is to ensure our patients' safety and to do no harm. The important thing is that every single member of the theatre team is equally important in ensuring this basic ethical principle. And it's incredibly important. And for hospital managers and people in charge of institutions, the whole team needs to be on the same page and acting in the best interest of the patient. And if there's any member of the team who has issues, personal problems, whatever, they need to be dealt with, because everybody's focus needs to be in the best interest of the patient. And the most simple, straightforward ASA1 patient can die if we're not all, rowing in the same direction and considering our role in the team. And I'm going to share a case with you, which is fairly well known and has been in the literature. So the whole team needs to act in the best interest of the patient. And that's got to be the overriding ethical principle and under which we all work in theatre. And the key components for me are the surgical safety checklist, but it's not the be all and end all. And after a lot of reading, I've come to the conclusion that it's definitely not the be all and end all. It's incredibly important, but there are other factors. And the 2 other factors for me are situational awareness and a just culture. And I'll share those with you shortly. Now, how do we go about and tackle this? And we all have a role to play. So there are enablers and there are disablers or roadblocks. Now, the enablers are firstly the use of the surgical safety checklist. And there's no doubt that it's an important component of what we do in our operating theatres every day. And the 3 important steps are the sign-in before the induction of anesthesia, and the never events that can be prevented by doing the sign-in properly are operating on the wrong patient. And you'd be amazed at how many patients have similar names, the same initial and surname. The wrong patient gets sent for, and heaven forbid, the wrong surgery could be performed. The timeout is before the skin incision, and the possible never events that can be prevented by doing that step of the surgical safety checklist is the wrong site or side, and this has happened before. or the wrong implant or prosthesis. And it's even happened in ophthalmological surgery. And I mean, that is too awful to contemplate, that the wrong eye is operated on. And then the time out of the surgical pause, which is where a lot of institutions slip up. And it's after skin closure and before the patient leaves the theatre, and it's the scrub sister saying to the surgeon, scrubs and instruments are correct. And when I grew up way back when in anesthesia, firstly at Barra and then at the then Johannesburg Hospital, none of us moved out of that theatre until the sister had said that to the surgeon. And it doesn't always happen these days, and foreign bodies get left behind in patients, sadly. So is the surgical safety checklist an enabler? Yes, it is, but studies have come out. There's one from Ontario province in Canada where they found that there was really no difference in patient outcomes in safety events or never events in their province, in their specific hospitals that they studied. So they looked at why, and it's recommended that, number one needs to modify the surgical safety checklist to fit your environment. So if you're running just a day case center or pediatrics or whatever, the surgical safety checklist needs to be modified for your specific theatre environment. It also needs to be followed properly and correctly. And then it is an enabler. But even if it's correctly implemented and prevents never events, patient harm may still occur. And that's the important thing. The surgical safety checklist is not everything. And why and how would patient harm occur? And there are two major issues that we see time and time again occur in theatres, our own theatres, and that's a lack of situational awareness and an absence of a just culture. So what do I mean? There's a fantastic book for anybody who enjoys reading about safety and these sort of issues. And I know there are people who disagree that we can draw parallels to the aviation industry, but we can in some aspects of our practice. And you can see by the title, it's based partially on the way airline pilots think about safety and accidents where people die. So that's why it's been called black box thinking. But it's not written by a medic, and it's really worthwhile reading. And in this book is this case from the UK. She was an NHS patient, Elaine Bromley. And for those of you who know the Elaine Bromley story, I apologize, but I think it's not a bad thing to remind ourselves about Elaine Bromley. It happened in 2005. She was 37 years old. She was an ASA 1 patient. She came for routine elective sinus surgery, and it really was considered minor surgery. The anaesthetist was a specialist anaesthetist, and he saw her preoperatively, found no problems, placed the drip, and induced her with intravenously. He had decided to use a laryngeal mask airway, and he was unable to position it to seat the laryngeal mask, and her oxygen saturation dropped to 75%. He tried bag mask ventilation, and he was unable to. And heaven forbid, he gave a neuromuscular blocker. He tried to intubate and couldn't. So he now can't ventilate, can't intubate, and he's given a long-acting neuromuscular blocker. Her SATs dropped to 40%, her heart rate to 50 beats per minute. The anaesthetist from next door, also a specialist, arrived, and the ENT surgeon arrived. So we now had 2 consultant anaesthetists and a specialist ENT surgeon, and 3 nurses in the theatre. So this most senior of the 3 nurses went and fetched the trachea kit, the whole trachea set. She walked in and informed the doctors, here's the trachea set on a trolley, ready to go. And they cast a glance in her direction and ignored her. The consultants continued trying to intubate the patient. The nurse felt very junior compared with the 3 senior consultants and felt that it was not her place in this hierarchy in the theatre to remind them about the trachea kit again. Eventually, one of the doctors managed to intubate Elaine. She had been, and bear in mind, this was not written by a medical person, she'd been starved of oxygen for 20 minutes. The result was catastrophic hypoxic brain damage, and she died 13 days later. And it's quite interesting. The inquest, the whole process of the inquest findings are all available online. The family, after she died, made sure that everybody could learn the lessons from Elaine's death. And what really chilled me was the surgeon said to Martin Bromley, there were some problems during the anesthesia. It's just one of those things. Sometimes happens. Anaesthetists did their very best, but it didn't work out. It was a one-off. I'm so sorry. Now, I think those of us who are insured by a Medical Protection Society, this wouldn't go down well if that's what we said to our patients. It didn't work out. It was a one-off. I mean, this was elective surgery and anesthesia, or elective anesthesia in an ASA1 patient. And Martin Bromley is an exceptional man. And he had a different attitude to failure. Martin was, well, he still is, a captain, an airline pilot and a captain for British Airways. And pilots have a different attitude to failure. And their goal is to make sure it never happens again. And what went wrong that it, in order for that to have happened. And Martin Bromley saw it as a learning opportunity. And as I say, he and the entire family made sure that the entire inquest findings were available for anybody to read online, and so that people could learn what had gone wrong with Elaine. And very, very sad. She had 2 young children, an 11-year-old, I think, and a 9-year-old. And obviously their lives changed forever. So how does this case illustrate the lack of situational awareness? And it was simply the anaesthetists and the ENT surgeon, I guess, intubated her to death. So, and one sees it time and time again, and it happens with all of us. You can't get that arterial line in, and this is ridiculous. There's a huge pulse there, and a huge artery, and I should be able to get the arterial line in, and you just suddenly are unaware of the rest of the patient, the rest of the theatre, whatever's going on. And one loses situational awareness, and it's a terrible situation, and we all need to help each other and to train ourselves to focus on the whole patient and not just the one task that we are doing. And I guess it comes with experience and with time, but it still happens. You can be tired, you can be overworked, et cetera, and suddenly there's a lack of situational awareness in your theatre one day. And the absence of the just culture is really illustrated by this case, and that is that everybody that's part of the operating team is equal, or should be equal. And when the senior nurse arrived with the trachea set, the ENT surgeon should have said, "Thank you, let's trachea her," and that was it. But she was just the nurse, and that is often the problem when things go wrong. You can have a bleeding patient and the anaesthetist is busy with anatropes and blood and fluid and everything else, the surgeon's clamping and cutting and diathermizing and trying to find the bleeder. And the floor nurse says, guys, look how many soaked swabs are on the swab rack. And, you know, does everybody listen to the floor nurse who's pointing out how many soaked swabs are on the swab rack? So, and the airline industry has got just culture down to a T. But I think we can learn a lot from them and listen to each other as part of the theatre team. So how do we tackle this? And the enablers, as I've mentioned, the surgical safety checklist has a role to play. Our environment needs to be one of mutual respect and professionalism, and we need to have situational awareness. So if I'm putting up lines that are really difficult and a patient who's got absolutely no veins, I need to know, and I need to ensure that somebody else is watching my patient, watching the blood pressure, et cetera, et cetera. You know, and so we all need to look after each other and look after the patient. And it very often entails proper planning, and it applies to elective and emergency surgery. And I think the first step of the surgical safety checklist is incredibly important, and before the patient is anesthetized, because that's when the surgeon can share with us, this is a redo, I'm expecting adhesions, I'm expecting whatever. And you know, the anesthetist can say, yeah, well, the airway is terrible, and whatever else. And we can all share with each other before the patient is anesthetized, that, you know, what we anticipate may be problematic, so that we can all have our roles to play, so that nobody gets in a situation where they're not aware of what's going on, and everybody needs to play their part and have a role of the surgical team. And every single member is equally important. And as I say, it applies to elective and emergency surgery. And the aviation industry have gone one step further, and that is the concept of the sterile cockpit or the sterile flight deck concept, and which we can also learn from. And their definition is that it involves the restriction of flight crew member activity to that which is operationally essential only during busy phases of flight. So taxiing out, taking off, the initial climb, final approach, landing, and taxiing in. So all the crucial times, everybody must not be talking, not be on cell phones, not be finding out if you enjoyed that movie or not, et cetera, et cetera. The activity is focused on those important aspects of that flight. And I think it applies equally to the equivalent periods in our operating theatres, and it requires every member of the team to focus on that one patient. I got a phone call one day. There was a cesarean section being done under spinal, and the scrub sister in a very loud voice was telling the surgeon what she'd done over the weekend, and the father of the child about to be born and the patient were, you know, she was awake, and they were incredibly upset by the conversation that was going on, and it was so inappropriate until that baby was out and everything was settled. So even if it's not difficult surgery or difficult anesthesia or difficult situation, I think we can learn a lot about the sterile cockpit, learn a lot from the sterile cockpit and sterile flight deck situation. How do we change the disablers, the roadblocks? And article after article after article mentions how medical training is hierarchical. And I'd like to think it's getting less hierarchical with time, but I know when I was at university, it was definitely hierarchical and sexist. And surgical specialization was definitely hierarchical. You know, I'd like to think that aspect of surgical specialization is changing, but perhaps it depends on the specialty. And I've called it a misperception that the surgeon is the captain of the ship. And it's not in the derogatory sense, but I find in the private sector, very often the surgeon's not even there for step 1 of the surgical safety checklist when the patient gets anesthetized. So while the patient's being anesthetized, there's no way the surgeon can be the captain of the ship when he or she is not even in theatre. But the important aspect of the captain of the ship is if the patient needs to be resuscitated, very often the anesthesiologist will take over that role. Or as I mentioned earlier, if the patient's bleeding and the surgeon's engrossed in stopping the bleeding, the anesthetist is pumping blood and putting the patients on inotropes, it may be the scrub sister or the floor nurse who ends up being the captain of the ship. And I think one needs to understand and accept that depending on the case and depending on the theatre. And the other issue is everybody will say, so-and-so, that happened because of a system error. And what the literature emphasizes is that we need to be trained and acknowledge that system errors always involve human errors because systems are created by us, by the judgments and actions of people. So a system error equals human error. And there's no such thing as a system malfunction because we are the ones who have created, improved, or done whatever with the system. So that is something we need to accept and understand and perhaps interrogate. I think specific training, mentoring, and support is essential for the entire theatre team to have a mind shift. The issue of situational awareness, the just culture, and the sterile cockpit. I think it may require a mind shift in some theatres. And as I mentioned, in the case of Elaine Bromley, she didn't die of a systems failure. She died from human error. It was pure human error that caused her death. And it was wrong judgment, wrong decision-making. And when the senior theatre nurse went to fetch the trachea set and informed the team, she was glared at. So, how dare she speak out in the middle of a crisis? And I mean, Elaine Bromley could still be alive today, I guess. The Tenerife airport disaster was one of the worst in aviation history. There were 583 deaths, and there was a KLM plane, and I can't remember the other plane, but the KLM pilot, the captain, was getting impatient because there was heavy mist, heavy fog, and he hadn't been given the go-ahead by the tower that he could start taxiing. And the first officer knew they hadn't had the go-ahead. The first officer knew there was a problem, but he didn't feel empowered to speak up. There was, they didn't have, in those days, the aviation industry did not have the concept of a just culture. And the KLM pilot just said, I'm leaving. Sorry, we're going. I'm not waiting any longer, and caused one of the worst aviation disasters with almost 600 deaths. And then, as I mentioned earlier, every team member needs to be situationally aware of each other's roles and how they can assist if needs be. So the concept of, all of this is referred to as organizational ethics in our theatre environment. So don't skip the steps in the surgical safety checklist. And even that first step before the anesthetic starts, no matter how simple the case, and no matter that you've worked with the same team for 3, 4, 5, 6 years, and you know everybody, and what's the point of introducing ourselves to each other? There's more to it than that. It's discussing the patient and what the possible problems may be with this case. And then, of course, the surgical pause at the end. If it's 10 o'clock at night and the patient's going to ICU, don't skip the swabs and instruments are correct step, because you've no idea how many near misses there are where swabs are missing. Should you do an X-ray? oh gosh, the X-ray, the swabs that we used are not radio opaque. They don't have that blue thread in them, so they won't show up on X-ray. So what do we do if we can't find the swabs that are missing? It's honestly not worth it, and it's not worth subjecting our patients to it, no matter what the time of day or night, or no matter how long that case has been. Allow the just culture. Every member of the team is entitled to speak up, and not allowing the various members of the team to speak up is unprofessional. And this was an interesting comment. It's not my comment. It was made in the American Medical Journal, American Medical Association Journal of Ethics. The article's called Time Out, the Professional and Organizational Ethics of Speaking Up in the OR. And the comment is, when senior surgeons are seen to be willing to spend time on the how and the why of the time out, the actions can support and improve interprofessional communication and patient safety in the OR. And as I say, that comes from the American Medical Association Journal of Ethics. And finally, some comments from our aviation colleagues. Neil Clark is a pilot who's involved, very, very involved in passenger safety, and has a company called the Human Factor Hub. And he spoke at one of the Medical Protection Society sponsored Ethics for All, not last year, the year before. And does a lot of work with various companies. They do work for the NHS. They do work in the mining industry just to improve safety, and applying these principles, situational awareness, just culture, various checklists to ensure safety. So it's not just for medical situations. And Neil basically says, when people understand human behavior, safety is present. When they become effective communicators, safety is present. When people cooperate effectively in teams, safety is present. When people are more situationally aware, safety is present. When people are effective decision makers, safety is present. And yet our systems still fail our patients, especially perioperatively. When systems value relationships before task, safety is present. Remember, relationships before task. Are locally attuned and responsive, safety is present. Are always on, safety is present. Are resilient and continually improving, safety is present. Thank you. And please all come to our All Africa Congress later this year. Thank you, Dr. Bila.
Thank you very much, Prof. Lundgren. It's quite a good start in the year that we attune our minds, knowing that, whatever we do this year, ethics and patient behavior is paramount in how we manage our patients. And the talk is not only about, we went straight into the theater, but as we continue, we'll move out of the theater into the wards and into the consulting rooms and into the community, just to ensure that we value human lives and that we also value relationships, because this human hub factor, as you've explained it, when we put that at the top of our agenda in terms of patient safety, then we're able to preserve lives. Yeah. And this will also help us to, two things that we can achieve is to decrease litigations and secondly, to ensure patient safety, that patients come into the theaters, to the hospitals, and they live a life and very well. Thank you very much for putting this alive.
That's a pleasure. That what that surgeon said to Martin Bromley when Elaine Bromley died. I mean, we've got to learn to speak to relatives. I mean, that was dreadful. The way he said, "Oh, it was an accident. Sorry, these things happen." I mean, we don't get taught to speak to relatives or to patients, and I think that's something else we can work on how to ethically and truthfully speak to our patients or relatives.
Yeah. So we need to know how to talk to each other as colleagues. We need to know how to speak to patients, and we need to talk to how to speak to the relatives. And I think I like that factor that when you spoke about the captain of the ship, and that the roles interchange during the course of the operation, and that and also to bring back the respect for nurses in the theaters also, because once we have that attitude, we can save lives. You mentioned the fact that.
Yeah, sorry.
No, go ahead.
No, if you look at the leadership literature, and you look at the leadership literature in theatre, in the operating room, it's quite interesting because they also talk about the captain of the ship may change in the course of one case. So it's not just this patient safety literature and looking at checklists and situational awareness, etc., that comments on it. The leadership literature also comments on the same aspects.
Yeah, I'm sure all of us would love to get hold of that book that you mentioned, and also to read about Elaine Bromley, so that at least if there's anything that we picked up from this presentation tonight, is those two matters that you've brought to our attention. You mentioned that in the private sector in particular, I think in exposure, not only one particular setting, group, is that you found that the cases commence without the surgeon. And is there any reason why is it like that? And what can we mitigate? What can we do to mitigate against this?
You see, when the checklist was, the checklist has been around since 2009. Well, 2009 was the original publication. And so the checklist has been around for a while. And the initial checklist is you must all introduce yourselves to each other, et cetera, et cetera. And in the private sector, there are specific teams. Surgeons like to work with that scrub sister, anesthetists like to have that anesthetic nurse, et cetera, et cetera. And so, but that doesn't necessarily always happen. People are ill, people take leave, et cetera, et cetera. And so it was largely, we need to introduce ourselves to each other, and then the anesthetist can start. But for me, there's more to it than that. It's discussing the case. And has anybody ordered blood for this patient? That's one of the tick boxes before you start the case. Is the patient likely to bleed? Is their blood ordered? And if you've assumed that everybody else has ordered the blood and there's no blood, well, then maybe the case shouldn't start. So it's just an observation I've made. But having said that, I was at Barra, as you mentioned, and you were, for how many years? And the checklist wasn't necessarily done very well at all in the public sector. I'm not sure at other institutions. So, it's an observation I've made. There are some surgeons who are meticulous, who are there before the patient is anesthetized. And when I had quite significant surgery last year, I was pleased that the entire team was there before I was anesthetized. But I think they knew that this was one of my hobby horses, so they made sure everybody was there. But I know that surgeon is always there before the patient is anesthetized. But there are some surgeons who aren't. They're busy consulting, and they're in the wards, and they're all over. And I don't know, maybe we should ask our colleagues. But I do think, everybody should be there. Likewise, everybody should be around at the end for that swabs and instruments are correct.
Definitely, yeah. No, thank you very much for that input. Colleagues, thank you very much. If you have any question, please do not hesitate to post your questions in the chat box, or just raise your hand, and we'll ask you to unmute yourself so that you may speak. And just to indicate to all colleagues, I see the questions about whether the presentation will be made available. Well, we've spoken to Prof. Lundgren, and she was generously agreed to avail the presentation. It will be in a PDF format, and I think something that we say that respect the propriety of the presenters, and that if you need to use this presentations, you'll have to speak to them first. But generally, we just give you the PDF position. I see Michael Blackburn, your hand is. Yeah, if you can unmute yourself and just ask the question.
Mark's a pilot as well.
Oh, a pilot and anesthetist. Okay. Go ahead, Dr. Blackburn.
Thanks very much. Thanks, Prof, for a great talk. You mentioned briefly teams, and I know that we all like to work with our preferred teams. Is there any research or evidence to show that having teams change randomly due to staffing constraints or the will of theatre management or that kind of thing adversely impacts patient safety? Or should the processes protect the patient even though there's a late and sudden unexpected team change?
So, Mark, in my reading, and as I say, there's a pile of literature, and which I did read. As long as your checklist is so, let's start with the checklist as one of the three pillars, or what I consider the three recommended pillars. As long as your checklist is your checklist for your institution, and you follow those steps, and everybody in the theatre is aware of what the patients come for and what's going to be done, and et cetera, all the details of the case, there are no differences in outcome that I have found. If I have, you'll be the first to know, but and I'll let you know. But in my reading, no, as long as the correct processes are followed.
Thanks so much.
Thanks, Dr. Blackburn. Much appreciated that talk, and thanks for joining us tonight. There's a question from Dr. Dingan Matabane. I'm not sure if I'm able to. Yeah, I'll read it, Prof. Lundgren. If you understand it, you can just go ahead. It says, can someone add a phrase, situational anticipation, e.g., difficult airway trolley, e.g., video laryngoscope choice of LMA over endotracheal intubation with an ET tube, or risk of migration of an LMA airway space between the surgeon and anesthetist, a risk factor?
Sorry, Dr. Bila, I don't actually understand the question. Situational anticipation.
Yeah, I'm finding it
is
difficult, but I think what is talking about is situational anticipation.
So I mean, that's in fact what the nurse did in the case of Elaine Bromley. It was she anticipated, so she could see. I mean, to have a no intubate, no ventilate, and to have given a long-acting muscle relaxant is every anaesthetist's nightmare. And she kept her cool and went and got the trachea set. So it was situational. It was anticipation, and the lack of situational awareness was on the part of the anaesthetist and the ENT surgeon. And I mean, there was an ENT surgeon with a trachea set in front of him, and he didn't make use of it. So yes, situational anticipation. I mean, I don't think the anaesthetist ever imagined it would be, no, can't ventilate, can't intubate scenario, but at least there was somebody who had the anticipation, but sadly it was ignored.
Yeah, it was a sad story. And talk about surgical safety checklist, and you spoke there about the surgical pause also. And also, before the patient is wheeled into the operating theatre room, should the surgeon also meet the patient and discuss the case together with the anesthetist outside the operating theatre room at the reception area?
Well, I think
can that help to alleviate
I think if you work with the same surgeon, I was in private practice, wow, many years ago. and part-time private practice, and not RWAPSing. I was part-time private practice, and I worked with the same surgeon. And when the list was booked, the surgeon would phone me and say, this patient, I did mainly cardiacs and vascular and a little bit of ENT. And the surgeon would say, this is a problem with this case, and this is a problem with that case, et cetera, et cetera. So, we discussed the patient beforehand. There was no such thing as the surgical safety checklist in those days. And so I knew kind of what the issues were going to be with the patients. But if you've got a very busy private practice with high turnover cases, I think it's important at some stage that you discuss it with the surgeon. It doesn't have to be outside before the patient gets wheeled in necessarily. Yeah. So, I mean, it just depends on one's practice. I see Rogan Pillai's got his hand up.
Yeah, okay, yeah, Dr. Pillai, go ahead and unmute yourself and ask your question.
Thank you, Dr. Pillai, and thank you very much, Professor Lundgren, for an excellent presentation. This is more of a comment than a question.
Yeah.
I think it's very commonly neglected, especially with ENT surgeons during so-called minor cases, that the space that the anesthetist works in is in fact their surgical field. So I think it's very important for an ENT surgeon, of all surgeons, to actually be present, especially at the time of induction and at the time of extubation of a patient, because this is critical. It's exactly like taking off and landing an aircraft. And this is when the problems happen when ENT surgery happens, because the secretions, the work in the area of the airway that's done by the ENT surgeon is actually what challenges the anesthesia.
So you're always there, Rogan?
I am always there for the last 44 years.
Yay, fantastic.
44 years, that's a long time, sure.
Yeah, I think the problem really is that, these the ENT conditions are relegated to the arena of being minor surgery, and I think that every tonsillectomy is in fact quite a serious indictment on the patient's airway. Thank you very much, Prof. Lund.
Yeah.
Thanks, Rogan. Thanks for that contribution.
Thanks a lot, yeah. Yeah, there's another question that's sent to us directly, Prof. Lundgren. Thank you very much for your presentation. Do you think that the team should change if there's a severe adverse effect? I mean, adverse, yeah.
If there's a severe adverse event?
Yes, adverse event, yeah. Should the team change?
No. I think the important thing after an adverse event with that team is to sit and talk about it. I think the whole team should go and talk to the family if the patient has died or the patient's unconscious or whatever. I think the whole team, even if only one person speaks, the whole team should go as a team, and then you sit down and you talk about the case.
Yes.
I mean, my last death, my last death in private practice, when I was in private practice, was a liver resection, and she died of bleeding, and she was a young lady of 36. And I mean, she walked into hospital the previous day, and the surgeons couldn't control the bleeding. The porta hepatis just fell apart, and I sent them for tea and tried to catch up, and there was just drip, drip, drip on the floor. And she eventually died, and me, for all my, everything I've got to say to everybody about everything always, I burst into tears. I was so shattered, and pulled myself together, went with the surgeon and the scrub sister, the entire team, and we went and spoke to the husband outside, and it was hard, but the surgeon spoke. And then we went and sat down and we talked about it before we even, and we had to carry on the list. It was a vascular list. There were another 3 or 4 cases, and we sat down and we talked about it, and we said, right, we've got to bash on, and we did. So I don't think one has to split the team. No, I think you all know each other, but I mean, every situation's different. But I think it's important to as a team to then sit. You must talk about that case, so that there's no blame. There must not be blame, and that's so good about the airline industry is they use, one slip up. I mean, there was a plane recently, an Airlink plane that skid on the runway somewhere in Mozambique. And nobody was injured, everything was fine. But the first thing they'll all sit and do as a team is talk about it and what will we do next time? What was there anything we did wrong? Did we miss steps in a checklist, etc., etc.? So I don't think it's necessary to change the team. I'm trying to understand this.
Yeah, definitely. I think that's the message you should. It's like Bafana. When they lost the first, when they lost the game against Mali, we didn't change the coach, we didn't change the team. We just had a pep talk, I suppose. And the next game, they did well. Thank you very much. There's for Dr. Ngai, it's a comment that I thought, I knew that the informed consent was going to come in. It's an issue about informed consent.
Yes,
and she says one of the habits is adopted. Yeah, your comments on that?
No, I agree. I agree. We must not assume informed consent. Always check. I absolutely agree. But remember, our informed consent, if you're the anesthetist, must be for your anesthetic. And unless it's an issue of joint responsibility like positioning or diathermy or one of those sort of joint responsibility things, we need consent for our anesthetic and the surgeon. But I agree with your comment. Always check.
Yeah. Another question that's been sent is, for how long does informed consent remain valid before the surgery? Sometimes the doctors, surgeons would see a patient a week or two before the surgery, and they've signed informed consent. And does it expire?
So there's nothing in the law. There's nothing in the HPCSA ethical guidelines. There's nothing in the National Health Act. There's nothing in the Children's Act. The only thing, if you ask MPS or you ask the HPCSA, the guiding principle is it's valid as long as the patient's condition hasn't changed. I mean, I think a year or 6 months is probably a bit long, but if the patient gave consent last week or the week before and their condition has not changed, so they haven't become unconscious or they haven't developed DKA or uncontrolled hypertension or gone into cardiac failure, they're still the same as they were, then it's still valid consent. That's not what I say, that's what MPS
Yeah, I'm sure this is the last one. Okay, no, thanks a lot for, I thought that was the last one. There's a comment here by Homuso Mabani that lapses in patient safety occur because we don't report or discuss near misses. If we did, then incidents would decrease significantly. You agree with that?
I agree with that, and that's why we need a no blame culture. And sadly, we don't have a no blame culture, but that's what the airline industry has, is a no blame culture. And I agree that we don't report or discuss near misses, and that's why M&Ms are useful. Is that you talk about things and you hear the near misses. I mean, the issues of situational awareness where the anaesthetists are so preoccupied with something they've forget about the rest of the patient, and the surgeon or the anesthetic nurse steps in. Those should be discussed because they are near misses. But you're right, Cyril. I don't know if the nurse should repeatedly reminded them. 2005, there was such a hierarchy in a lot of the NHS operating theatres that I mean, if only the nurse had repeated herself. But yeah. Theatre
Definitely, yeah.
hierarchy is quite scary for nurses. I mean, you only have to have grown up with Jannie Lowe in the Cape as head of surgery, and you know, Marburg and Buerta and all those guys at CMJ, and sure, we were all terrified of them. Never mind, never mind the just culture. So yeah. Prof.
Yeah.
Makanyani's got a hand up.
Yes, yeah, just go ahead, Prof. Just say.
Thank you very much. Thanks very much, Prof. Lundgren, for this wonderful talk, really insightful. I was cut off for a while, but I wanted to comment after Rogan Pillay commented on the importance of ENTs being present when the patient is going an induction. I was about to say that actually all surgeons, I believe, who work around the face, like us, ophthalmologists, certainly need to be there during the induction because firstly, we need to make sure that the head is positioned correctly, and because there shouldn't be any moving around the patient around after the anesthetist has given the anesthesia to this patient. And also to make sure that we know exactly where I will be sitting as a surgeon and where the anesthetist is going to be, because I come in with a lot of gadgets myself, with a chair and all sorts of foot plates that I shouldn't be stepping on the patient's or the anesthetist's wires and tubes. So yes, it is extremely important, especially those of us who work around the face and the head. Thank you very much.
Thanks a lot, Professor Mapunyan. She's also one of our members of the risk committee. Thanks for being part of this discussion this evening. There's a question also from Athos Papadouros. Where is it now? She wants to know the theatre nurse in charge could also intervene on behalf of the nurse who brought the trachea. I think we speak about the same case.
Sure. I agree. I agree. Yeah.
Any last words from your side, from yourself, Prof. Lundgren?
No, so just to answer, Dr. Bila, how does different surnames of parent and child impact on the validity of the consent forms for a surgical procedure? There's a very good guide that was published. There's a very good guide on that. I don't know, I can't remember if it's an addendum of the Children's Act. I was looking for it now under my consent file, but if Winnie Lebete wants to give Dr. Bila or somebody her email details, I'm happy, because I'm happy to send it. It's, you know, can a caregiver give consent? How do you prove that you're the official legal guardian, et cetera, et cetera. So I'm happy to, if Winnie wants to give her details to anybody, to send that to you, because it's a very, very, very useful document. Or I'm happy to send it to Dr. Bila and he can send it to whoever wants it.
No, thanks a lot. Yeah, would appreciate that. Yeah, no, yeah, they can just write. Yeah, I'll send. I will put it on the database on the email list.
Okay.
Yeah. Thank you very much. It's really right on time. Good. It's good for the year. Yeah.
Good.
Good. Yeah. No, and I think in that short 45 minutes or so, it was quite an intense presentation that had a lot of information that we can clean and use for useful service this year, and make sure that this year at least we keep our patients safe, and we make sure that there's a just culture and that we adhere to the surgical safety checklist at all times. It's been a wonderful time to have you, Prof. Lundgren, and you quite had the honor of opening this year's webinars. And what a way of starting it. It's been wonderful. We started on a high note with more than 400 participants at
Sure.
some stage who logged in. We know that we got only about 350 registered, but I think we got even more people logging in. And also just want to thank you, colleagues, and for
Thank
logging
you,
in
everybody.
this evening. Yeah, for being part of this. We hope that you'll still come even next week. For the next coming 4 or 5 weeks, we'll be having the members of our risk committee doing presentations and bringing some highlights of good clinical practice that we've seen last year as we were sharing. We looked at what are the areas of improvement that you can have from the comments that we've had for the webinars that we've had. And it's quite exciting that we want to respond to your requests also to bring this. But as we've said in the past, please do not hesitate to avail yourselves, anyone who wants to do presentations in the future. You've seen my email, that just send us a one-liner to say your name and a topic you want to cover for the coming few months this year. And I just want to thank...
if I can say to Nandipa, Faith and Guane, I'll send as a theatre nurse, they accept the consent form when the parent guardian signs, etc., etc. I'll send you a whole thing on the children's consent, because there are specific guidelines. There was a very, very good guide written by UCT, by pediatricians at UCT as well. So I'll put those together and send them to you to circulate. So Nandipa, you'll get something.
Yeah, sure.
Sorry,
Thanks
Dr.
a lot. Yeah. All the documents that you sent to us, we will share them gladly.
Okay.
All those yeah. So as I was saying, just thanks to everyone, and thanks to Clinics Health Group for giving us the opportunity to continue hosting these webinars, and thanks to Gamo, who's been helping us in the last...
Thank you.
Yeah, and we hope to see you again next week, and please have a good evening, and let's hope Bafana bring it home. Thanks. Good night.